Hi, this is Evelyn here. Today I'm going to talk about benign prostatic hyperplasia, BPH, also known as enlarged prostate. Benign prostatic hyperplasia. Benign means it's not cancerous, it hasn't spread. Prostatic means the prostate gland, and the hyperplasia means the enlargement. So that's what that means. So what is a prostate? The prostate is located under the bladder. It's kind of in between the bladder and the penis. So the prostate is supposed to secrete a fluid that will mix with sperm to form a semen. That's the function of the prostate. BPH is common among men who are age 50 and above, and there are 11.24 million men suffering from BPH globally. And that statistic was actually measured in 2019. There are 50% of men with BPH. So because of the stigma involved with BPH in relation to lower urinary tract symptoms, such as UTI, not able to pee, not able to empty your bladder, dribbling at the end while you pee, all of this is associated with BPH. So there's a stigma involved. Most men don't want to talk about it, and they don't want to address the concern. So which is why I'm here today, to just kind of educate people that it's not something to be ashamed of. BPH is a common condition, and there's 50% of men globally that's actually affected by BPH. So it is something to talk about, and there's some medication and other surgery that can fix the condition. So what are the risk factors for BPH? One of them will be family history. So it is said that genetically, there's some specific genes that kind of cause the prostate to grow, so enlarge. So if your family, your dad has that, you might, a man with a dad that has that, will follow the son as well. So that's how that works. And it says obesity. Obesity also causes the prostate to be enlarged. The reason being that with the extra fat, that will result in you producing more estrogen. With estrogen being produced, then that can cause the prostate to increase and enlarge. The third one would be diabetes, specifically type 2 diabetes. It's as a result of, with the type 2 diabetes, we all know what insulin is produced, but you can't use the insulin. So insulin is elevated in the bloodstream. So because of that, elevated insulin can trigger growth of prostate, which will cause that to enlarge. And the fourth one will be inactivity. So you're not doing anything, you're just sitting down, you're not doing much of any physical activities, which will actually kind of relate to gaining weight, extra fat, more estrogen, and that will end up happening. You are going to get enlarged prostate. What are the signs and symptoms of BPH? One of them is frequent and urgent need to urinate. You pretty much just have very little to pee, but the urge is so much. You will go there and you pee, and it's just a little. Another one will be peeing, especially at night, nocturia. And the third one would be just difficulty starting urine. It's just hard for you to start peeing. And another one will be weak urine stream. So you kind of start and stop, you pee a little bit, you stop, you pee a little bit, you stop. And the fifth one would be dribbling at the end of urination. Sometimes you can have blood in your urine, you can end up with a UTI, and sometimes you cannot pee at all. Before I talk about the diagnosis and treatment of BPH, I kind of want to dive into how urine is made. So that way we kind of know why it's important to pee. That not peeing can put you at a state of shock, and that can lead to that. So which is why I kind of want to tell you what urine excretion, especially for urine, is very important, because there's that waste that needs to get out of your body. So not able to pee, you're retaining that waste in your body, and you can end up with a lot of complications. So which is why I kind of wanted to explain from get-go the pathophysiology of how urine is made. The start of urine being made actually starts from the kidney. The kidney is what does all of that. So which is why I want to start with defining how the urine is made, starting from the kidney. The kidney is a bean-line shape, the size of a fist, that's located below the rib cage, one on each side of the spine. So the kidney is what filters blood plasma by removing metabolic waste and toxic and excrete them through urine. So that's how that works. So let's go back to the pathophysiology here, so that way I can tell you how that blood plasma comes in and all that stuff. So we have blood coming from the aorta after it's been oxygenated. Now it's moving into the renal artery, which is the big vessels that supply blood to the kidney. So the renal artery, from the renal arteries, the arteries divide into smaller arteries. And then from that division, they divide again in what they call arterial. The kidney, one kidney is made up of millions and millions of nephrons. The nephron is made up of the Bowman capsule or the glomerular capsule and the long renal tubule. So they're made up of two of that. So the big head would be the Bowman capsule, and then the long tubule would be the long renal tubule. So remember, in the Bowman capsule, we have hydrostatic pressure, osmotic pressure working in there, trying to filter the blood plasma in there to allow certain things to go through, to allow certain things not to go through. Most times they allow small molecules to go through, like something like inorganic iron, amino acid, glucose, and water. They allow that to go through, and that will go from the Bowman capsule into the renal long tubule. That's how that works, and it's reabsorption, secretion, and absorption. And all of this are also controlled by hormonal, sympathetic nervous system, hydrostatic pressure, osmotic pressure, all of this, because the kidney does release an enzyme called renin. They regulate our blood pressure, the secretions. There's a lot of things going in the kidney, right? So we're just filtering all these toxins, removing creatinine, excess creatinine from the blood, they're removing urea from the blood, they're removing all this metabolic waste out of the blood, and to filter so that they can form urine and excrete it out. That's how that works, right? There's what I call a glomerular filtration rate, which is the amount of filter per minute. So that's actually done from the Bowman capsule, and all of that work together to allow the kidney work to eliminate waste. In a healthy person, the total filtration volume for a healthy person is about 150 liter to 180 liter per day. However, only 1% of that is excreted as urine. So the rest of the 99% will go back to the blood plasma to be reabsorbed when they move to the long renal tubule. So that's how that works. Even the kidney tend to reabsorb all of the amino acid and sugar back into the bloodstream, and half of the nitrogenous waste and other metabolic waste is being reabsorbed back into the bloodstream. This is because the kidney does not eliminate all the waste at the same time. They want to maintain that safe metabolic waste. They want to maintain it so that way they don't eliminate all of them out at once. So it's more of like an homeostasis, where they want to keep the body, like the body, at a very stable condition. Because if you eliminate all the waste and you end up your body not being in homeostasis, that can also lead to other complications. So the kidney wants to make sure that, you know, it's safe to eliminate some things, and some of them are being reabsorbed back into the blood, and some of them are being excreted out to be excreted and eliminated as urine. So as I mentioned, the long renal tubule, all of that with the loop of Henle, the collecting ducts, all of that is filtering, is reabsorption and secretion happening, sodium potassium pump. There's all of this stuff in there that's actually regulating. There's hormonal regulation, auto-regulation, those kinds of things. Sympathetic nervous system actually is working with this, all of this happening. So the main thing is this. Another thing I want to talk about is that when a person is dehydrated, so what usually happens is that the loop of Henle will create an osmotic pressure that will kind of draw water. It will reabsorb water back into the bloodstream. So that's why when you're dehydrated, your urine is so dark. That's because there's an osmolarity pressure that's being created as a result from the loop of Henle that's actually drawing water, reabsorbing water into the bloodstream because you're dehydrated, and you're excreting more sodium and bringing more water into the bloodstream. But what's going to end up happening is that your urine is going to be really concentrated, it's really dark. So that's why one indicator for dehydration would be dark urine. You're not drinking enough water, so you tell people to drink more water. So that's how that works. And at the end of the day, from the loop of urine to the collecting duct. From the collecting duct of the kidney, urine is going to move down to the two ureters, all the way down to the bladder. So the sitting in the bladder. The bladder is an organ that stores urine for you. So once the bladder is full, it's going to send signal to the brain that hey, your bladder is full. And what end up happening is going to trigger, and then the sphincter that's covering that where the bladder sits there, that connect the bladder and the urethra, is going to relax and it's going to open. Once it opens, urine is going to go through from the bladder into the urethra. From the urethra, it's going to end up where you expel this urine. So that's how that works. So now back to the prostate gland. The prostate gland is underneath the bladder. The size of the prostate gland is supposed to be a little bit smaller. So when it's enlarged, remember that the urethra passes through the bladder and through this prostate. So when the prostate becomes enlarged, it's going to put pressure on the urethra. So when it put pressure on the urethra, so the urine that was supposed to come out of the bladder is not able to come out. So you're going to end up with what they call urinary retention. You're not able to pee. So all of that signs and symptoms that I described earlier, where you have difficulty in urinating or even starting urine, weak stream of urine where you pee, you start to pee and you stop. You start to pee, all of that stuff, blood in urine and all that stuff. Those are the signs and symptoms of BPH. So that are things that you need to watch out for. So how do you know you have BPH, and how do you get diagnosed with BPH? One of them is a test called PSA. It's called prostate specific antigen. So it's basically taking your blood and then testing for PSA. A number that is less than 4 ng per ml will be normal. If it's greater than that, you specifically have a BPH or even prostate cancer. So they have to kind of do more tests to differentiate between a BPH and prostate cancer. The second one would be POSTVOID residual. So basically asking you to pee and see if you're able to empty your bladder completely. So in that case, they ask you to pee. They do a bladder scan to see how much urine is left in your bladder. If there's still much urine left, you know you have. So in this case, I want to make sure you don't have a urinary retention after the bladder scan is done. The third one is transurethral ultrasound, where they put a light scope in your rectum to kind of check and evaluate your prostate. So they're basically checking to see the size of your prostate and see how that works. The fourth one is a cystoscopy, where they put a flexible instrument into your urethra. The goal is to check the size of the prostate and if the urethra is actually working. So that's how they do that. So in this case with the cystoscopy, it's very painful. You might end up being on anesthetic or any type of medication that will help to ease the pain. BPH is not a major concern, although there's some stigma I mentioned that is involved with it, which is why there's medication that can treat it. Medication such as FLOMAX. FLOMAX is an alpha blocker. Basically what they're doing is that they're supposed to relax the muscles around the prostate and the muscles around the bladder, so that way that will ease for you to pee. So another medication would be finasteride. The goal of finasteride is actually an hormonal treatment. It's basically to reduce the size of the prostate, so that way shrink the prostate, and that way that will ease pressure in the urethra so you can pee and won't cause all of that signs and symptoms. Another way they can treat BPH is through surgery. One surgery I've seen done is a transurethral resection of the prostate, or they put a light scope in your urethra, and the goal is that they want to kind of remove all of the prostate, but not the outer part of the prostate. In this case, that will kind of ease your symptoms right away. And typically after the surgery, they put an indwelling catheter in a person for a couple of days. It's just a temporary thing. And then we can do a trial void to see if you can pee. Once you're able to pee, you don't need the catheter anymore. And then it's being removed and all that stuff. So that's how that works. It's not something to be ashamed about. So it's just hope you have a nice day.